Hello and welcome back. Again, my name is Maureen Oscadal and I'm a registered nurse based in Seattle, Washington, and I'm here with the University of Washington's Addictions, Drug, and Alcohol Institute to share the last video of the Nurse Care Manager Foundational Series. In this last video, we will cover the topic of patient engagement and retention in care, and we'll get started now. So situating engagement in the treatment process, what we really want to highlight is that it is step one. It wraps around everything else that we do. That includes treatment with medications for opioid use disorder. It includes the nursing assessment, looking at the patient's mental health, and psychosocial needs. And it includes the crisis management, or those things or issues that need to be addressed first before we address other aspects of care. Engagement wraps around all of these, always. There really is no treatment process without patient engagement. So why is engagement important? Well, we just said it wraps around everything. It's a critical component in a treatment process. But more specifically to the work that we do, engagement is important because engaging patients in medication for opioid use disorder treatment is critical to effective and life-saving care for people living with opioid use disorder. And that's because evidence shows that these medications, particularly buprenorphine and methadone, reduce the risk of opioid overdose. And this is important because overdose rates from opioids in our communities are very high and increasing due to the influx of unregulated fentanyl into the drug supply. And here we see evidence of this. This is a slide that's been shown in previous videos. It's a graph showing the Washington statewide opioid death rates starting around 2000, going up until the year 2022. And what we can see is indicated by this red line is that overdose death rates from any opioid in the state have increased dramatically between 2019 and 2022. And the driving factor behind that death rate is synthetic opioids, which includes fentanyl, and that's in the minty green, light blue color line that's really mirroring the red line, heading in the upward direction. So what we know is that this surge in opioid overdose deaths is due to the high prevalence of unregulated fentanyl in the drug supply. And again, we know from the evidence that medications for opioid use disorder reduce the risk of overdose, and this is particularly important given the high levels of fentanyl that are present in the drug supply. Later in this video, we'll talk about how interpersonal interactions impact engagement. But it's also important to note here that medication dose plays an important role in engagement. First, we're going to look at this meta-analysis of 21 randomized control trials that was published in 2012. And the findings from this study showed that high dose, or buprenorphine doses between 16 milligrams and 32 milligrams, was associated with better retention in treatment and fewer urine drug screens positive for opioids and cocaine. Next, this is a secondary analysis that looked at opioid-dependent individuals participating in opioid treatment programs between the years 2006 and 2009. And the participants were randomized to receive either buprenorphine or methadone for 24 weeks. And in the buprenorphine arm, what the researchers found was that buprenorphine doses above 16 milligrams a day resulted in less illicit use and greater retention in treatment. Another finding in the study was that about 25% of buprenorphine patients dropped out before the end of month 1. And this suggests that that first month of treatment is an important time to ensure that patients are on an adequate therapeutic dose to ensure better treatment outcomes. And here we have a more recent retrospective cohort study published in 2023 out of Baltimore, Maryland. And the researchers here were looking at buprenorphine doses of 16 milligrams daily compared to buprenorphine doses of greater than 16 milligrams daily. And they compared the two groups to see which groups had higher rates of retention. And as you can see here in the findings, for the group that got greater than 16 milligrams daily, there were higher rates of retention both at 30 days and at 90 days. And finally, we have a review that was published in 2023 advocating for higher doses of buprenorphine. The key points from this article highlighted that the FDA recommends daily dosing of 16 milligrams a day, with a range of 4 milligrams to 24 milligrams. The authors of this article argue that doses of 32 milligrams or greater increase the safety and retention in care, and that dose limits of less than 32 milligrams a day may put patients at risk in the context of fentanyl. The key takeaway here is that buprenorphine dose matters, and that buprenorphine doses of greater than 16 milligrams are associated with improved early engagement and better retention and care. And with the influx of fentanyl into the drug supply, it is likely that higher doses of buprenorphine will be needed to achieve therapeutic effect for patients who are engaged in medication for opioid use disorder treatment. And here are some practical approaches to improving patient engagement. And these are more logistical tips and tricks. So first, you want to review program and clinic expectations early. It's important for patients to know these things. Next, you want to collect all the contact information you can and find out which mode of contact the patient prefers. You can also ask patients if there's other people in their lives that they would like involved in their care, and get release of information as needed. If you're able to do outreach, find out where patients spend their time and plan to visit them there. If you're planning to call the patient, ask them, when is your preferred time to get a phone call? For patients that don't have a phone, try to brainstorm early on how you can connect with them in the absence of phone contact. This could be by email, it could be via the electronic health record messaging system. If you are able to outreach, it's wonderful to be able to do that, but having a plan in place in advance can be really helpful. If you have a phone number for patients to call, make sure you get that phone number saved in their phone so they have it when they need it. And remember that text messaging can be good, especially when voicemails are full. Finally, when you're seeing a patient, either by phone or in person, try to schedule follow-up at that time rather than waiting to do it later. It's best to have follow-up scheduled for the next visit when you're seeing the person. And now we're going to briefly touch on the role of stigma, because stigma is a tremendous barrier to engagement and retention and care. And as members of the healthcare team, we are sources of support for our patients. And as such, our goal should be to reduce the role of stigma in the treatment that patients are getting as much as possible. This means using person-first language. It means educating ourselves about substance use disorders. And when we're talking about substance use disorders, that we talk about them as chronic, treatable medical conditions. And finally, when we're speaking to patients as well as to colleagues, that we communicate respectfully, honestly, and with non-judgment and support. So when we're talking about substance use and substance use disorders, the language that we use really matters. And it matters not only when we're talking to the patients or the people who use drugs that we serve, it also matters when we're talking to other people in our life, our loved ones, our colleagues. So using recommended language helps to avoid stigma, both within the conversations we have with patients, as well as within our lives more globally. So on this slide, we have some recommended language and some language to avoid on the right-hand side. So instead of using the term abuse, it's recommended that we use the term use, misuse, or used other than prescribed. Instead of describing someone or a lab result as clean or dirty, We talk about lab results as testing negative for or positive for. And then if we're talking about a person who is in recovery, we can say they are abstinent from X, Y, and Z substance. We want to avoid describing individuals as addicts or users, and again, using person-first language. For example, a person with substance use disorder or a person who uses drugs. Similarly, with drinking alcohol, we want to avoid describing someone as a drunk or an alcoholic, and we would prefer to call them a person with alcohol use disorder. And finally, for someone who's in recovery, rather than calling someone a former addict, it's best to call them someone in recovery, a person in recovery. And what you'll notice is people who have a lived experience with substance use and substance use disorders may use language that is different than what's recommended on this slide, and that's okay. But as clinicians, as care managers, it's best to use language that is as non-judgmental as possible, and these are some suggestions, ironically from the National Institute of Drug Abuse that was published in 2021. So we all are still learning, even the entity that is putting out this recommendation, because abuse is still in the title of that department. So now the next piece of engagement is rapport and building rapport, because whether we're talking to a person in person or over the phone, one of the very first steps in engaging patients in care is establishing rapport. And rapport really is foundational to this process. It's foundational to engagement, and it's foundational to retention. And here we see some of the building blocks to building rapport with a patient. At the foundation, we have respect, followed by authenticity, empathy, gratitude, support, curiosity, and honesty. And in previous years, when we've done this foundational series live, nurses who have participated have listed the following steps that they engage in to building rapport. Communicating with patients that they are experts in their own lives and learning from patients about what they're already doing to keep themselves and their community safe. Acknowledge autonomy. Express hope for the patient. Active listening. Frequent communication. Show empathy. Help patients to feel comfortable and meet patients at their level. Consistent positivity. Refrain from judgment. Allow for off-topic conversation. Ask permission. Reassure the patient that they are safe. Remember personal details about the patient and bring them up later. Show and express gratitude for the patient showing up and sharing. And finally, unconditional positive regard. And part of the reason that rapport is so important is because we're trying to develop an alliance with the patient, a working alliance, so that we can provide care. And looking at human helping relationships, including counseling, coaching, and teaching, the strength of the working alliance is a strong predictor of future outcomes. Across all human helping relationships, the strength of the working alliance tells you how well things are going and strongly predicts future outcomes. So the question is, how do we develop these alliances so that we can provide good care? In psychotherapy, the optimal therapeutic alliance is achieved when both the patient and the therapist share beliefs about the treatment goals and view the tasks needed to achieve those goals as useful and relevant. Both must commit to their specific roles, and this alliance is built on a personal relationship of confidence and regard between the therapist and the patient, with the patient trusting the therapist's ability to help and the therapist believing the patient has the resources to engage in the tasks needed to achieve the goals. The alliance influences the outcome by enabling the patient to accept, follow, and believe in the treatment being prescribed. And so these are the elements of a working alliance. They include the bond or the rapport and mutual respect between the therapist, and in this case, that's the care manager, and the patient. The goals are those things that are generated by the patient and mutually agreed upon between the patient and the care manager. And the tasks are those things that need to be done in order to achieve the goal. They should be concrete, doable steps that address barriers that a patient might encounter when trying to achieve the goal. So a critical element of the working alliance is the bond between the care manager or clinician and the patient. An important way to do that is to elicit the patient's story. We want to learn, who are they? How do they understand their drug use? What else do they have going on in their life? Where do they work? Are they in school? Where do they live? Who are the important people in their lives? And what are the hobbies or activities that they enjoy doing? How do they understand their current situation? And what are their perceived cons and pros of the treatment that you're working toward? During this time, it can be helpful to provide feedback, to reflect, summarize, and clarify to make sure we understand what the patient is telling us. We can ask permission before we offer education, and we can also be reviewing program expectations. The next element in the working alliance is goals, and these are the patient's goals. How do they see their future? How does that connect to opioid use disorder treatment? What are they wanting to work towards right now? Sometimes when we see patients initially, they talk about wanting to stop using substances. That can be a big motivator. We might hear patients say, I just don't want to be using any drugs anymore. I want to get clean, quote unquote. As the care manager, it's important to dig deeper. What does this mean in terms of the big picture for the patient? What does their life look like when they've stopped using the substances that they want to stop using? And how does treatment fit into this future plan? These big picture goals are important, but they're often long-term, and it can be very helpful and important to also talk about short-term goals. One thing I like to do at my visits with my patients, whether it's on the phone or in person, is to ask them what they want to work on during the time frame between this visit and our next visit. These don't need to be goals related to opioid use disorder treatment. And then it's helpful to revisit these goals, check in, ask the patient, how did it go? What do they think would be helpful for next time? And when we're talking about goals, it's helpful to really make these goals SMART. And SMART goals are goals that are specific, measurable, achievable, relevant, and time-bound. So once you've identified the goal that the patient wants to work toward, the next step is to elicit commitment, or the ask. This is where we find out from the patient what concrete steps they're prepared to do right now to work towards the achievable goal. It's helpful and important to explore potential barriers. These can be practical, psychological, cultural, social, or financial. Another important piece to highlight here is that getting off track from moving toward a goal is a normal part of the process. What matters is, how do people return to getting back on track? So over the course of treatment, there can be instances where it's important to think about stepping up engagement or returning to a focus on engagement. And some of those instances are listed here. For example, at a time when maybe the clinician and the patient don't agree on the goals of care, or they don't agree on the tasks needed to achieve those goals. The bond between the clinician and the patient might weaken, or rapport can be thwarted unpredictably. These things can happen at any time in your relationship with a patient. And because engagement wraps around everything, it's important during these instances to return to a focus on engagement when these things happen. Illustrated here, we see a reciprocal effect between provider style, patient style, and the alliance between the two. And the only piece that we have a direct influence on is our own wheel, our provider style. So when we're thinking about how can we influence the working alliance, one of the pieces we have to think about is, what is our provider style? What style of care is going to be most effective to complement the patient style and improve the success of the working alliance? And as we said at the beginning, engagement wraps around everything. And at the center is the relationship between the care manager and the patient. And I want to close this video and this series by describing what Carl Rogers calls unconditional positive regard. And that's the attitude of complete acceptance and love, whether for yourself or someone else. And it doesn't mean that you accept each and every action by the person, but that you accept who they are at a deeper level. And as Carl Rogers says, the kind of caring that the client-centered therapist desires to achieve is gullible caring, in which clients are accepted as they say they are, not with a lurking suspicion in the therapist's minds of what they may in fact be otherwise. This attitude is not stupidity on the therapist's part, Carl says. It is the kind of attitude that is most likely to lead to trust. And with that, I'd like to thank you for watching. This concludes the Nurse Care Manager Foundational Video Series. You can find additional educational content about substance use disorders, and substance use treatment at our website, learnabouttreatment.org.